On behalf of the AAAS and the HIV Medicine Association, the Center for Global Health Policy at IDSA, and Science Magazine, we are pleased to be here in the auditorium of the AAAS. My name is Sten Vermund. I work at Vanderbilt University, heading the Institute for Global Health there, and had responsibilities in the HIV Prevention Trials Network. Headed that network for 6 years until turning over the reins from Quraish Abdul Karim and myself to Wafel Sadr and Mike Cohen just last month. This symposium has to do with treatment as prevention, from science to implementation. I think you're going to have a lot of frank talk this evening. I think there's going to be folks who are, on one hand, passing on the inspiration of what science called the scientific breakthrough of the year last year, to the bald realities of the transition to full implementation. Challenges at every level, be they policy, economic, be they public health infrastructure, whether in the U.S. Or internationally, especially in Africa. So we are very lucky to have recruited the speakers we have this evening. I wanted to introduce the first one. Myron Cohen, known as Mike to all of us, is the Herbert Bate Distinguished Professor of Medicine, Microbiology, Immunology, and Public Health at UNC, runs their Global Health Institute, a university-wide entity, has been feted and honored for a number of years, but especially this year, for this extraordinary achievement that he's about to tell you about, the HPTN 052 then and now. Mike.
Thanks. Good evening, and I think I'm going to, physician scientist types are genetically incapable of not using slides. So in fact, I get up in the morning and talk to my wife and say, can I show the first slide? Because I would not want to talk to her about anything without a slide. And recently I had to give a talk to some students, and I asked a friend of mine who's a psychiatrist at Wisconsin who Sten knows, and I said, I'm really anxious about talking without slides because other people wearing robes and stuff don't use slides. And I said, I can talk without slides, right? No problem. And there was this long pause that psychiatrists use that, that you fill it in. He said, no, you really can't talk without those slides. And he said, without those slides, those PowerPoint slides, you'll be powerless and pointless. So Nancy and I were just talking, and I asked her about the slides, and I said, we have the slides, don't we? And so I feel greatly relieved, and I feel okay. So, we did a study called HPTN 052, and that study is a randomized controlled trial designed to ask a really straightforward question, and that is the difference between immediate, and by the way, I wonder if these are the right slides, just out of curiosity. I think these will be okay, but they're more than I would have used. Okay, I'm going to talk really, how long do I have, Christine? Oh, right. Thank you. Okay. So then, can we have a break? We'll have a break after my first hour. So I'm going to go through these slides because they are kind of interesting. I'm going to talk really fast because most of you are native English speakers. So we decided to do a study called HPTN 052 that was a randomized controlled trial of early versus delayed therapy. The early therapy would randomize people to immediate therapy at high CD4 counts. The delayed therapy would not be delayed to jeopardize health, but would allow an opportunity where transmission might occur. But yet we use condoms and every other device to prevent transmission. So we know we'd lower the rate of transmission, and we had two endpoints that were moving at the same time, and only one endpoint has been reported in detail. On Friday, we'll report the other endpoint. So the first endpoint that we were studying was, were we able to affect transmission? And the second endpoint is, do people who start their pills earlier benefit from the time at which we start them? We had 4 questions that we thought and still think are important. Do these drugs stop HIV transmission? And if they do stop transmission, this is important. What do we tell 34 million infected people? There's a lot of HIV-infected people at this meeting, and they and their providers need this information. This has become a really big deal in communication to patients. And then there's a bigger issue. But we're also, so the bigger issue is, can we see enough of a benefit to have a population-level effect using these drugs? And if we're going to try and get a population-level effect, try and treat our way out of the epidemic, which most of us believe is going to be difficult, if not impossible, what are the barriers to that aspiration? This study was conducted in Asia and Africa and South America, and then 2 lonely couples live in the United States. But 278 couples live in South America, and 954 live in Africa, and 531 live in Asia. And these are couples where the infected person is the index case. They're HIV positive and treated or having delayed treatment, and then the partner is HIV negative, proven to be HIV negative. We oversampled Africa because that's the epicenter of the epidemic. By the way, can you understand me at this rate of speed?
Yeah.
I'm from North Carolina, and this is not acceptable for that. This would not be acceptable in that location. In Alabama, where Sten used to live, I'd be my first slide. This would be, So because I can talk very, very fast. So thank you for that. So we're treating these couples are enrolled at 13 sites in 9 countries. So this is the basic study. And what happened was the study was started actually in 2000. And so from 2000 to 2011, we worked on this study. Obviously, it took us a long time to do everything we needed to do. And during that time, there were no papers, no abstracts, no publications, and no reports. This is not the way to have a career. Okay, so doesn't make you popular to show nothing for millions and millions of dollars invested. On April 28th of last year, the oversight board called the DSMB asked us to make the results public. The study is ongoing. It wasn't stopped. We presented interim results. Why did they want us to make the results public? Because they were so dramatic from their point of view. They had observed in the hidden data from us 39 transmission events. 11 of those transmission events using the tools of molecular virology are unlinked, whereas 28 were linked. One person transmitted to another. But of those linked transmission, only 1 came from a person who was receiving therapy. The other 28 came from people not receiving therapy. This led to the conclusion that over these 2 years, in the face of use of condoms and best counseling we can do, we were reducing HIV transmission by 96% or more. Now, why did this work? This is a biology experiment. We're not so brilliant. We were suppressing viremia. So at every patient visit of the infected person, we were measuring the virus in their blood. At first, they came every month. Then they came every 3 months. But when they came, they were managed different than than patients would normally be managed. We were proving that the virus was suppressed. And so the blue bars across the top are the percent of people in the clinic who have suppressed viremia. And it's 95 to 100% at every visit. If it wasn't suppressed, we'd investigate why it wasn't suppressed. So what did we do? A really, I think, a careful biology experiment showing if people took their pills, suppressed their viremia, we rendered them, for the most part, no longer contagious. I say the most part because of the 1 person. Now, the 1 person shown on this slide, and I don't want to get too medical in this kind of after-dinner discussion, but in this one person, we can see on the black bar, and I don't know if I have a pointer, maybe. Okay, in the black bar over here, we can see the person has HIV infection, and they come in and they have a partner who's definitely negative. We treat them. They are suppressed. At less than 400 means there's no virus in their blood. Their partner converts. We can then take the virus that they got. They got 1 virus. 82% of people only get 1 virus, and that's an important point. So we took that 1 virus, and we can compare the parent virus in this person to this 1 virus that's growing. By using the mutations that have evolved, we can estimate within some broad range when the virus was transmitted. And all the evidence suggests the virus was transmitted right around therapy was started. So this was not a failure of the idea. The person had unprotected intercourse too soon. At least that's our conclusion, which we're publishing this summer. We also demonstrated, I won't dwell on this, clinical benefit, and that clinical benefit was considered as an endpoint, but on Friday we'll report in great detail all the clinical detail. Thursday at 4:30, we'll report, Dr. Beatrice Grinstein will report in great detail all the clinical benefits. There'll be a p-value assigned to this, and this will be the first randomized controlled trial done to demonstrate the benefits at high CD4 count. The median CD4 count is at 446. That's the highest that's been tested to date. So what happened next, to try and get to Nancy or whoever's speaking next, or if Nancy's next? all HIV-infected subjects were offered antiviral therapy, and at this point, 96% of the subjects have been retained in the study, 85% have the same partner, and all but 70 or 80 have now started an antiviral therapy. There's a message there. Not everyone, no matter what you say to them, starts an antiviral therapy. One thing we're studying very carefully is when couples participate in antiviral therapy, they seem to adhere better than random people. And we think of this as altruistic adherence. And with Dr. Klitzman at Columbia, we're studying altruistic adherence in this these patients. Why are we going on? Durability, durability, durability. We've said that at 2.1 years, we saw 96% prevention. This needs to be durable to be of benefit to the patient and of benefit to society. So we're studying durability. As I've already indicated, Dr. Grinstein will present when to start. Dr. Mayer has already presented sexual behavior, which did not change for the worse in our subjects. Dr. Chen presented details about progression of disease. And on Friday, Dr. Rochelle Walensky will present, do you save money, or is it cost effective to start treatment earlier? Using the 052 results, she'll compare India and South Africa before 052 and with the 052 data. And I would recommend highly that those who are here on Friday listen to her results. I do believe that Dr. Grinstein's and Dr. Walensky's presentations will get a lot of publicity, their press releases, and so on and so forth. So this takes us to kind of the next question as I talk fast. We go from the patient benefit, which we feel very secure about, to population. And in Health Affairs had the entire issue devoted to PEPFAR. Dr. Payne and I and many others wrote an article about the effects of this study on PEPFAR policies. Those are shown here, and basically PEPFAR really worked incredibly quickly to embrace the findings and say, well, these findings have to translate into some PEPFAR policies of broader treatment and earlier treatment, and we're very proud of that fact. WHO put out couples guidelines, which are very straightforward. For couples, make sure both partners know exactly what these results show, and according to WHO, treat an infected partner. That is, if they're infected, they should be treated, because that would likely help to prevent a transmission event. We see a glimmer of hope. We see a study from, and now we get to population. We see Dr. Frank Tanzer and KwaZulu-Natal looking at the availability of antiviral therapy. The green is no antiviral therapy in communities in KZN. The orange is more and more antiviral therapy to communities that have more than 40% antiviral therapy. And in those communities that get so much antiviral therapy, he's following 16,000 people, and he's looking for seroconversion. He argues that in looking at the seroconversion and the home address of people who develop incident HIV, that for every 10% increase in antiviral therapy, he sees a 2% fall in new cases of HIV. Now, this is ecology. Ecology is complicated and difficult. People drop out of studies, there's a lot of confounding factors, but it's exciting to the investigators to see the glimmer of hope. There are more than 50 studies planned to look at the treatment as prevention, 3 very large ones supported by USAID and CDC and the Gates Foundation and the NIH. The HPTM, the network that I now run, and Sten Vermund is a big leader in this study. We're very involved in one called HPTN 071. It's actually directed by 2 British folks, Richard Hayes and Sarah Fiedler. This is a study now designed to take the 052 finding plus everything else we know how to do, and to see if the 052 finding plus everything else will reduce the incidence, new cases of HIV in communities that get the best we have to offer. This is trying to take a couple study and roll it out into a community to see if the benefit can be realized at the community level. So I think this is an unbelievable time for scientists. Normally, scientists are just complaining about politicians and saying, you know, well, they don't understand, they don't give us any money, they're not interested, they're just terrible. But now we have politicians driving scientists. So Hillary Clinton, in her quite remarkable performances and referring with President Obama to the AIDS-free generation, is saying to the scientists, in a complete reversal of the paradigm, you're not acting fast enough, you're not going fast enough, do everything you know how to do. Her argument is to use integrated combination prevention to get the maximal benefit out of 30 years of research. Her argument, which I think most of us embrace, is if we do everything we know how to do, it's not unreasonable to expect a very positive benefit. But there's another thought that's really critical. We're not going to stop the epidemic with the tools we have now. The way we'll deal with this epidemic is with a vaccine, which we're making great progress on, and Bart Haynes is giving a talk at 8 o'clock tomorrow morning, which I expect will be very inspiring because we've made terrific progress, and Dr. Robinson's here, one of the world's leaders in vaccine development, and there's terrific progress in understanding what we need to cure HIV. Today, Dr. David Margolis had a paper in Nature, which is a step towards trying to cure HIV. So to deal with the epidemic, we're going to need combinations of better curative therapy, which could have one kind of effect, and a vaccine, which has another kind of effect. Where we are now with treatment and all of our integrated preventions is a bridge to the future. And what we need to do is use these tools, in my opinion, to bridge to the future, and the future will look different. And so it's an exciting time in this field with the tools that have been developed. Thank you so much for listening. Thank you. Let me apologize for me in advance today.
Mike has another engagement up at the conference, so he'll slip out, but he's got a little time, so he'll stick with us as long as he can. Thanks, Mike. That was terrific and right on time. Nancy Patey, and I've known since the 1980s. She's had a singular focus and amazing tenacity to answer core questions around HIV transmission and prevention of HIV transmission. She started with a major heterosexual cohort in the state of California. She's worked extensively internationally, including in Zimbabwe, and has had a trifecta of jobs over the past 3 years, notably a senior technical advisor for the Office of Global AIDS Coordination, namely PEPFAR, and has spearheaded a lot of the transition from the we don't do any research mentality of early PEPFAR to the we do suitable research that's actually going to improve and inform the efficiency and impact of our programs, which is the current attitude, and has worked in her day job at the University of California, Berkeley, where she's professor of epidemiology. So without further ado, Nancy.
Thanks, Stan. Thanks. I'd just like to say that I think we strive to do more than suitable research. We try to do excellent research. I'm just really picking up on some points that Mike already made, and that is this was from the Secretary's speech. John, when was it? It wasn't World AIDS Day? Was it World AIDS Day? November, okay. Where she said, we recently granted more than, well, actually, sorry, before I get into that, let me talk to you for a minute. So the name of this symposium is Science to Implementation. So what we're trying to do, as Mike said, when the findings from 052 hit and we realized the potential for treatment as prevention, it was consultation after consultation. We did try to, as fast as we can, come up with guidelines which are published in a version of Health Affairs that just came out. So what we're trying to do then is to think about, now that you have these recommendations and you have this science, what does that mean for PEPFAR implementation? So what we are trying to do is to, although the title of this is Science to Implementation, is focus on implementation science. That is to say, it's not just, as Mike said, he did a great biological experiment. So what we're trying to do is to figure out what do you do with that? How do you implement that? What does a program look like? And as part of that implementation, there is an evaluation, and it really is, not even arguably, it is science, but it's more of a focus on implementation. So that's kind of my bridge from Mike's talk to mine. Okay, now back to the Secretary, who in November said, we recently granted more than $50 million to 3 of the world's leading academic institutions to develop rigorous studies that test what works in various settings. Today, I'm pleased to announce that we're stepping up our efforts. The U.S., through PEPFAR, will commit an additional $60 million to rapidly scale up combination prevention in 4 countries in sub-Saharan Africa and rigorously measure the impact. And for any of you who heard her speech yesterday, she reaffirmed her commitment to combination prevention, but the anchor of all of the 3 combination prevention projects that PEPFAR is sponsoring is treatment for prevention. So let's see how this works. Is it just this? Yeah. Oh, no, I guess not. Well, so much for that. Is there, I tell them when to switch? No. Forward, please.
On the left-hand side, I think. Yeah. This one. Yeah. On the left-hand side of the rondel.
The other line. Let me see. Yeah.
It's only because you're older than me that you know how
I
to
know.
do that.
Here, let me help you. Can I?
Sit down, sit down. The way that we structured this, I think, as probably all of you know, that there are several agencies that are actually part of PEPFAR, and we took the largest agencies and made awards to them, to NIH, to CDC, and USAID. But in order, this is really not business as usual, or I'm relatively new to PEPFAR, so maybe it's been done in the past, but it's definitely new to me, is that we are working really hard to coordinate these three studies. And insofar as all of them are similar, that they have a treatment for prevention component and are looking at other components of prevention, we want to be able to at the beginning, be able to consider questions that might lend themselves to meta-analysis, to pooling, and I'll talk a little bit about that later. But although they're three independent studies, we are working really hard to get the most of them so that we can have a combined approach as well. And that's led by OGAC. Now let me see if I remember how to do this. Right. So Mike, thank you very much. This is a busy slide. Oh, I'm going to skip over. Is this also a pointer? No. Yes?
The highest up arrow.
And you are able to do it because you're younger than me. Right? So Mike already described, this is the NIH study, which is being done in Zambia and South Africa, which is being done with the London School of Hygiene and NIH and through the PTN. And as a hallmark of this study, I'll go over, I'm going to talk about each one in slightly more detail in a less complicated way. But fundamentally, I'll just highlight the treatment for prevention. This is universal. Universal test and treat. It's a 3-arm study where they're looking, and all of these studies have enormous linkages to circumcision, to PMTCT, massive scale-up of testing. There's behavioral prevention that's backing up all of them. But again, the core is treatment to prevention. And you can just to get an idea, this is in 21 communities, and we're looking at incidence in all of these studies because there isn't a reliable incidence assay right now. All of the studies, although they're all randomized clustered trials, some of them are randomized to the intervention. In the NIH study, there's 2 arms. One is a combination intervention with universal test and treat. One is without, and one is standard care. They all have embedded population-based cohorts that go through all of the communities so that we can have accurate measures of incidence. USAID, working with Johns Hopkins, is doing a study in Iringa. And here, what they're doing is actually just shoring up the linkage to care among people who are currently eligible for treatment that is less than 350. So they're not at this point doing a new treatment strategy based on, for example, 052, but their hypothesis is that even with existing eligibility criteria, the linkages are so bad that if they shore that up, that would have a major effect. And so the arms, that's a 2-arm trial. And again, in this trial, they're actually including interventions for a conditional cash transfer for young women, interventions for female sex workers, and again, it'll be this combination in some communities compared to standard care. And then in Botswana, which is Harvard with CDC, this is with Max Essex. Actually, this is, this is not working. This is, I left out the PIs. This is Richard Hayes. JHU is David Chilentano, and Botswana is Max Essex and Victor Di Gratola. And here their testing strategy is based on viral load rather than CD4 count. And I'll show you that in a more simple version. So just to look at this, I mean, the things to point out is that these are huge studies. So we're really taking what Mike did with his couple study, and it's they're all community cluster designs. There's thousands of people who are being followed up. They're all looking at HIV incidence, and they're all powered to look for around a 50% measure of effect in the intervention arm. This is a little bit more detail. I mean, this is just showing you maps of where it is. This is the NIH study and London School of Hygiene. These are the communities in Zambia and South Africa on the bottom. I mean, this is a lot of level of details. And, this is just showing it more simply. So it's universal test and treat with a combination prevention compared to active linkages to care at national guidelines with a combination prevention compared to what's standard. I think that's probably enough. And moving on to USAID, JHU, which is in the Iringa region. These are just the communities. Here, as I said before, it's enhanced testing to link to care based on current eligibility guidelines, enhanced male circumcision. There's, as I said, conditional cash transfer. This is 2 arms. The sample size is 12 versus 12 in communities. This is the CDC Botswana study. Here, to give you a little bit more detail about the treatment for prevention, it's ART for people infected with CD4s less than 350 or that have HIV RNA greater than 1,000. Then here also there's going to be enhanced linkages to care, male circumcision, point of care CD4 count. There are massive studies with a significant portfolio of prevention interventions. And I just thought I would highlight some of the unique features of each study. Now, that said, we are all working together. So although everything's it's somewhat of a moving target. So although I'm highlighting these as unique factors, in fact, they may become common factors. So a JHU is doing a fingerprint tracking with which both for their population-based cohort as a way to look at what services they have, but also in the community, because one of the real challenges of this kind of study, everything hinges on scale, and everything hinges on coverage. In other words, power is based on having a certain proportion of the population get male circumcised, having a certain proportion of the population be linked to care, a high proportion of the population, massive, be linked to tests. So what we don't want to do is not be able to test our hypothesis because coverage is poor. So linkage and being able to measure that is everything. So JHU is doing portable fingerprint readers. The London School and NIH has community, and actually there are people here, including Mike and David Burns and Tom, who know more about this study than I do, with these community healthcare workers, these teams that are responsible for doing testing, linking people to services. They're actually even doing data collection. It's an incredibly innovative way that they're involving people in the community to be involved in both delivering the interventions, making sure they happen, and also collecting the data to make sure that we can follow tracking. As I said before, a unique aspect of the CDC study is the viral load testing. And also they're going to be doing in-depth phenotypic analysis of virus to track transmission events. So just to close, all of this were amazing amounts of harmonization. There are working groups, which I have to say are going infinitely better than I ever could have imagined. Everyone is really into working together. It's really exciting to be a part of it. We have a group on statistical analysis, harmonizing the data collection, of which Sten is the chair. Economic indicators, monitoring and evaluation. We're having one common DSMB for all 3 studies, which I think is something new. This is really I would say, an unprecedented effort. I mean, insofar as you may know about PEPFAR, there's implementing partners and there's people who do evaluation. In this case, the academic researchers, the implementing partners, all of the people involved in the USG teams, and country stakeholders, including the Minister of Health, community-based organizations, and civil society, are all working on the same team. We have to come up with the same protocol for implementation, figure out the budgets, do the IRB, work together, and this is really, I think, an example in this respect of implementation science, because if you're going to do implementation science, you have to work with the implementation people. So it's a new way of doing business, and we're really excited, and hopefully we'll see some starting recruitment early in the new year. Thanks.
Thank you, Nancy. I'm happy to introduce Till Berninghausen, who is on the faculty at Harvard and works with the Africa Center. For those of you who don't know the Africa Center, it's been around for a number of years, a very substantial institution in rural KwaZulu-Natal. And we're very pleased to have Till talk to us about the issues of the impact, performance, and economic evaluation of treatment as prevention, because this study, largely funded by the ANRS, the French AIDS agency, is actually been in the field already for its pilot work, unlike the 3 studies that you just heard about coming from the U.S. So, Till, we're looking forward to this.
Thank you. Thank you, Stan, for the introduction. I will, in my presentation, talk about 2 issues. The first one is an introduction of, in a sense, the 4th treatment as prevention trial, which was not included in Nancy's presentation yet, and I hope in future presentations we will be included, or at least mentioned, and give you an update and introduce this particular trial, which is funded by the French National Research Organization for HIV, the AAAS. And then I will share some results. Some of them we presented at the AIDS conference and at the International AIDS and Economic Conference last week on impact evaluation of ART under current guidelines. And I think we find some encouraging results there regarding the economic spillover effects into households, own effects in ART patients, which have not previously been shown in such a way as we can show it. The Africa Center treatment as prevention trial has one simple hypothesis. We want to test whether frequent HIV testing of all members of an entire community, followed by immediate ART initiation of all HIV-infected people who we detect through testing, regardless of their immune functioning or clinical stage, will prevent onward transmission to reduce HIV incidence in the population. So we are focused solely on a treatment as prevention hypothesis, and we do not mix in scale-up of circumcision or other interventions. The PIs are Professors Marie-Louise Nouvelle and François Dabi, and the social science part here in this initial phase that we started in April this year is led by John Imrie and Franz Lert in France, and I'm looking after the economics and health systems part of this trial jointly with Professor Jean-Paul Marty. The trial in Zulu is called Ukupila Kwami, Ukupila Kwetu, My Health for Your Health. And we test in the intervention communities and in the control communities 3 times per year, all members of these communities. Then, after a rapid test communication, offer initiation in the intervention arm immediately, in the non-intervention arm, depending, of course, on CD4 count and clinical stage. And we have the start of this trial here. We have started in an initial phase, which can be viewed as a pilot phase, but which really, if we were successful in obtaining the money for the remaining communities, would be the first phase of a complete trial. We have started this trial here in 4 initial communities. This is the entire set of all communities that we've randomly allocated already to receiving TASP or being in the control arm. These little crosses here are the community clinics, the Department of Health clinics, and we have in total, hopefully in the future, 34 clusters, 17 in each arm, with a total population size of 42,000 people in this contained community in rural KwaZulu-Natal, where incidence is still extremely high. In our population-based surveillance, we measure an incidence of about 3 per 100 person year. So one of the highest adult HIV incidences still in this world. The initial phase has started, and here you see the 2 Department of Health clinics that are also involved, and we have added to those clinics both in the intervention arm and in the trial arm, where treatment as prevention can be accessed. In the home-based testing, we fingerprint and register fingerprints in all intervention and control enrollees. We do a complete population follow-up of everybody who is enrolled. So we have a complete population cohort, not a selected population cohort, as we do in the Africa Center population and demographic surveillance site. The fingerprinting has, of course, a effect that we can be very sure about our longitudinal follow-up, but we can do that as well in the population-based surveillance based on identification numbers and age and sex and names. But of course, the fingerprinting is a very strong measure to prevent spillover from the intervention community, where people are assigned in their homes to receive, if they want to, immediately ART in the intervention clinics to from the control arm spill over into the intervention community. So we can really prevent people in the non-intervention community in the control arm from accessing ART under task guidelines. So in that arm, of course, we provide follow-up wellness care and then initiate under the current status quo guidelines under 350 eligibility criterion CD4 count in South Africa. So that's essentially the introduction to our trial, and we have recently received the good news that another European funder has pledged a substantial amount to enable us to at least add on further communities, and we're still hoping to be able to do the full trial in a few years' time when we finish this first phase in 2 years' time. The second part of my presentation is a sharing of a number of results that I think are important and show us what the ART scale-up in this community has already achieved at this point. The community where we do our work here is in northern KwaZulu-Natal. These little red crosses are the Department of Health clinics. This is a demographic surveillance area of about 432 square kilometers, and we follow in this surveillance area about 80,000 people in about 11,000 households continuously over time, and are thus able to see things that other sites cannot see. We have a continuous data inflow on vital events, birth, death by cause of death, and every second year or every year we conduct a socioeconomic surveillance where we look after household assets and employment status, and an HIV health surveillance we conduct every year. The Wellcome Trust has just given us another 5 years of funding, so this will continue into the future for 5 more years. We link into this population base the data from the Klabisa Treatment and Care Program, which is the Department of Health program, which we support via PEPFAR, USAID money, and support, and we deliver jointly with the Department of Health ART in 17 primary care clinics, which are nurse-led. They are devolved. They were devolved from the start. So it's a real-life program with real-life retention and adherence issues, and we link via identification number, birth date, sex, and age people in the ART program into the population base. And this enables us to see a number of things. Here's an initial result on life expectancy. Of course, a population-based demographic surveillance site is dedicated to measure life expectancy. So we see here, going towards the ART rollout in South Africa, a sharp decline in life expectancy starting from the first point when we were able to measure life expectancy at 58, reduced to 52 by the year 2000, and then ART is rolled out in the public sector, is rapidly scaled up. We've now in 2010 measured population-based our ART coverage. At that time, under 200, it was 75% in 2000. So a very successful program that now has led, highly likely, to this immense recovery of life expectancy and even overshoot versus the 2000 baseline that we were able to measure here. So from 52 years to 60 years, an 8-year increase. Every 2 years, there's a 2-year increase in life expectancy. That's a dramatic change. That's complete population life expectancy, not increased life expectancy in ART people. This captures, for instance, our concerns about negative spillover effect on other health services. If we are concerned that ART crowds out maternal care, increases maternal mortality, this is total population life expectancy. This is the net effect, probably, of this large successful ART program. Here is the probability density function, and we see that here in 2003, the first year when we have data, there is a mass of death occurring here in the young ages that has now shifted slowly to the older ages here. And this initial high mortality here is probably still something that we can reduce. These are still AIDS and HIV-related deaths, so we would hope in the future to further shift this density mass into this area with increased ART scale-up in the coming years. And my colleague, my PhD student, Jacob Bohr, presented that today at the AAAS. The second result, and Myron has already mentioned our study that my colleague Frank Tanzer presented at CROI, where we followed 17,000 people who at baseline were HIV uninfected, and we see them individually, not ecologically, in their seroconversion, and then we regress the time to seroconversion, and we detect here over 8 years almost 1,500 seroconversions as opposed to maybe 30 in large trials that we conduct. So a very large and powerful study, 1,400 HIV seroconversions over 8 years. We regress seroconversion probability, controlling for sex, age, education, sexual behavior, on ART coverage in the surrounding communities where people live. And as the programs scale up, we update ART coverage, expressed as coverage of all positive people. And we see here an incidence reduction, or a reduction in the adjusted hazard ratios from baseline to about 40% in communities that have achieved a coverage of 30 to 40% of all positive people with ART. So a dramatic HIV incidence reduction seen in a longitudinal, large-scale study in rural KwaZulu-Natal. The last impact evaluation that we conducted is on the economic effects. And of course, we are very interested to see what happens to people who recover their health on ART. Are they economically maybe disadvantaged still when they have regained their health, or have they been able to come back into employment? And there were a number of clinical studies that preceded our studies which essentially see a trend going up. This is employment trend here, employment probability in people on ART. And that trend is interesting, but it is very hard to interpret because the baseline depends on when people seek care. The sicker people are, obviously, the less likely they are to be employed. And as CD4 count, for instance, increases, we might not see such a trend, but ART will still be extremely effective in maintaining people on employment. So what a population-based study gives us, it gives us a natural yardstick, a natural benchmark for such a trend. And we observe here the individuals who eventually, after 8 years of observation or so, go onto ART. We observe them in their employment, in their full employment potential when they're not yet suffering from the illness due to HIV, and then they fall ill, lose employment, and then we see that the recovery actually is almost nearly back to the baseline level. So people are able, over 4 years' time, to recover employment nearly perfectly. And this sluggish recovery here is due to the employment opportunities in this labor market. When we match healthy controls to the ART patients, we see that if you lose your job for other reasons, you recover employment just as slowly as ART patients do. The dip that we see here is, of course, a dead weight loss to society. That's a transaction cost because people need to again go out, expend money to find a new job. Employers need to hire someone, train the person they have lost. And these replacement costs, we think, could easily be avoided if we initiated earlier. The initiation here, on average, is at a median CD4 count of 116. So moving up to 350, for instance, would probably avoid this dead weight loss that we see in this loss and then recovery slowly over 4 years. When we look at household spillover effects, which is another question I think that has so far been unanswered, how do household members benefit from someone going onto ART? We see that using a very robust physical measure of household welfare or household wealth, a count of assets. We elicit in all households 27 assets, and on average a household in this area has 6.2 assets. And when we observe those households who have an index person who will eventually go onto ART, we see hardly any trend. So we see here a maintenance of assets when an index person in a household goes onto ART. And this could be due to an absence of an HIV effect, or it could be of an HIV effect on assets and an ART effect, recovering from the HIV effect, or it could be due to the fact that there are no such effects. So as a comparator, we look at households that instead of having someone succeeding in going onto ART and surviving, losing a household member because of an HIV-related death as diagnosed via a population-wide verbal autopsy. And what we see here is very striking. We see a similar initial assets count, and then going towards HIV-related death, households are losing their assets. 4 years after death, they continue to lose their assets, and then the household maintains a lower asset count over another 2 years. So the last result is a more cautious note when we think about treatment as prevention, and I've shown positive results on economic spillover and economic own effects in ART under current guidelines. But when we look at the incremental cost effectiveness of adding treatment as prevention to other interventions that we know are efficacious, it is likely that treatment as prevention is not at present has not the highest cost effectiveness. This is a study we presented yesterday where we run in an analytical model, an analytical mathematical model, different combination prevention scenarios against each other, and we use as a case South Africa. We scale up male medical circumcision. We compare that to a scale up of both medical male circumcision and ART, and then we add on TASP, and we run a range of scenarios, all scenarios you can think of essentially from baseline, and we see that in terms of infections averted, male medical circumcision is the most cost-effective intervention at present, ART then the second most present, and then we gain further due to TASP. When we look at death, which is arguably more important, we care about infections only because they lead to ill health, of course. We see that male medical circumcision and ART are approximately equally cost-effective, and we can explain that because male medical circumcision avoids death in the future after a lifetime because of averted infections. ART, of course, saves those people who are currently dying of HIV. And TASP in this particular study is cost-effective, but is only cost-effective at a much higher cost-effectiveness ratio than either male medical circumcision or ART. So in summary, we have started HIV prevention trial in rural KwaZulu-Natal. The first phase is fully funded. The second phase is partially funded. We have shown, I think, in impact evaluation studies, dramatic gains in life expectancy, incidence reductions, employment recovery in patients on ART, and a protection of household welfare due to ART. And it is possible that TASP is cost-effective, but it is also likely that it is much less cost-effective in the present state of the world than male medical circumcision and ART under current guidelines. And I think the ongoing treatment as prevention trials, including the one at the Africa Center, will provide us with more data on TASP effectiveness and spillover effects and economic effects. Thank you.
Yeah, thank you. Thank you, Till. I'm happy to introduce our next speaker. Blaine Cutler is working for the New York City Health Department in charge of HIV prevention in the Bureau of HIV/AIDS, and is both a physician and an epidemiologist, a former journalist, a former demographic editor, a real Renaissance woman. She's been one of the backbone founders of the study that she's about to tell you, describe to you.
Thank you. Thank you, Sten. I have to say, to come to a venue that's located on New York Avenue and have a lot of fast-talking people and share with you information about the Bronx makes a New Yorker feel right at home. So, actually, I'm not going to talk so much. I'm going to mention HPTN 065, but what I'm really going to do is put my implementer's hat on tonight and tell you a little bit about, from a completely different perspective, what it's like in New York City, how we went about making the recommendation we did last December. And so I want to start with a clip, a media clip that really got our attention when it was released on World AIDS Day 2011, about 8 months ago, on the day that we joined San Francisco in being the first 2 U.S. cities to recommend the universal offer of antiretroviral therapy. The clip comes from a writer named Mark Leon Goldberg, who wrote an article in a publication called the UN Dispatch, in which he stated, "I have seen the future of the global fight against HIV/AIDS, and it is New York City." Well, you can imagine that really got our attention. And Goldberg went on to say that one of the most fascinating developments this World AIDS Day has not come from Africa, Asia, or even Washington, D.C. Rather, it was an anodyne announcement from the New York City Health Commissioner, Thomas Farley, who said that antiretrovirals should be made available to anyone as soon as they are diagnosed with HIV. Now, flash forward these 8 months to IAS, and we find, if we go by the number of sessions focusing on some aspect of early treatment or the universal offer of antiretroviral treatment or treatment as prevention, that conceptually, at least, Mark Leon Goldberg's surprising statement was really not that off base. However, the central driving question at this conference, and I think of this moment in time, seems to me less whether this is going to happen, particularly starting in the countries like the United States, but how and how fast, given the political, financial, and socioeconomic factors on the ground. And also, as Mike Cohen said, this is a bridge to a vaccine or a cure. And how can we fully realize the benefits that this bridge has the power to confer? So what I want to do this evening, in about 8 minutes or less, is to give you the New York City experience as something of a case study on what we have already been doing to address the treatment cascade, why we made the recommendation we did, and how we're going to evaluate its impact. If one slide can summarize the 30-year epidemic, this is it. This is a complicated slide, but it provides a historical snapshot of the situation in New York City. And what I want you to focus on are these dark bars climbing to your right. And because these bars represent, with the success of treatment since the mid-1990s, what we've seen is a steady climb of persons successfully living with HIV in New York City rather than dying. So in New York City, we have now, as of June 30th, 2011, nearly 112,000 people in our city living with HIV. And every day, unless we have some sort of game changer, we face a task that's a kind of Sisyphean task. And by that I mean we face this challenge of continuing to try and drive down our numbers of new infections while the number of persons living with HIV and available to transmit the virus continues to climb. And despite that challenge, we've made some very important gains in the past years. In New York City, we've devoted an enormous amount of time, energy, and resources to scaling up HIV testing because we realize as the first step along the treatment cascade, all individual and public health benefits that can flow from viral suppression start with case finding and from individuals knowing their status. And Marx and others, as you know, and has often been cited, have shown that those who are unaware of their status likely account for more than half of all onward infections. And many of you have heard either Dr. Monica Sweeney or myself speak about these efforts, including our work at the jurisdictional level, building what we've called the Bronx Nose, and then Brooklyn Nose, and now, more globally, New York Nose, as a start to kind of really scale up and raise awareness about HIV testing, and subsequently partnering with NIH and CDC on HPTN 065, and more recently, our working to pass the first law of its kind in the United States, which became effective September 1st, 2010, requiring the offer of an HIV test to all persons aged 13 to 64 in emergency departments, inpatient settings, and outpatient primary care settings with limited exception. In part because of this work, we've seen a statistically significant increase in the percent of 18 to 64-year-old Bronx residents reporting ever having had an HIV test, with nearly 80% reporting they've ever been tested for HIV in 2010. An evaluation of some of this work was published in JADES about 4 weeks ago. This slide compares our recent measures or estimates in New York City on a number of key indicators to national measures or estimates for the same indicators. And our testing efforts have not been limited to the borough of the Bronx, but have had an impact citywide. It's now the case that more than 2/3 of all New Yorkers aged 18 to 64 report ever testing for HIV, which is 26 percentage points higher than the national estimate. And estimates for testing within the past 12 months have also exceeded national estimates. We've also tried in New York to get a local estimate for the percent of individuals living with HIV who are unaware of their status. And as many of you know, the percentage, the 20 to 21%, has been used a lot at the national level. In New York, we've had many older estimates, which were sero surveys looking at specific subpopulations, and they have varied from 5 to 27%. And they've looked at different populations, from sex workers to jail detainees. However, an excellent sero survey recently conducted by Lucia Torian and her team among all persons for whom blood was drawn in a large emergency department in the Bronx, which is, one could argue, a population more broadly representative than some of the older specific populations like jail detainees, has found an undiagnosis rate of 13.5%, and details of this study are being presented here at IAS. Also, unlike the incidence estimate for the nation as a whole, which has not really moved between 2006 and 2009, the incidence estimate for New York City using CDC's formula has trended downward, although this calculation, as many in the room are aware, is challenged for its imprecision, I would say. A measure called the transmission rate, characterized by David Holtgrave, which is calculated by dividing incidence by prevalence, is also lower in New York City at 2.8 per 100 persons living with HIV using 2009 data than the national estimate of 4.2 per 100 persons. And finally, while we're pleased that our share of persons with HIV who are virally suppressed is higher than the national estimate at 39% compared to 28% nationally, it's this treatment cascade, particularly the glaring gap between where we are, even at 39%, and the potential impact we could have were we able to improve upon each and every parameter shown, along with HPTN-052 results released last summer, and mounting evidence that patients who initiate ART earlier are less likely to suffer a variety of HIV-related complications, including cardiovascular disease, certain cancers, and deterioration of the immune system, that led us to make the recommendation of the universal offer of ART this past December. So these factors working in consort really tip the balance for us to find what seems to be rare in clinical medicine and public health, which appears to be a very strong win-win. And there's more data, as our other presenters are sharing with you, about this win-win, meaning a win for an individual's personal health outcome and a win for the community's public health outcome. I just wanted to make the point, and this slide summarizes some of the key evidence for an individual health benefit, that we made this recommendation based on not only a public health benefit, but very importantly, an individual's health benefit as well. We know that there is certainly more data that is forthcoming on this area, and not all studies have shown an individual health benefit, but this was factored into the decision to make this recommendation. The public health benefit of early ART has now been demonstrated in numerous ways, from modeling data in various parts of the world, to the success of ART to prevent transmission in other paradigms, including maternal to child transmission, post-exposure prophylaxis, and before HPTN-052, the biological plausibility of treatment to prevent transmission was demonstrated by Quinn and through various observational studies. But I would be less than forthright if I didn't. Unfortunately, Mike Cohen left because I wanted to gradually expand his ego by saying that HPTN-052 was something of a game changer in our decision-making process. Both the magnitude of the reduced HIV incidence shown by this study, the fact that there were individual health benefits demonstrated, and the potential this study suggested for significantly reduced mortality at the community level, morbidity, contributed to our decision to take the action we took last December. And we were quite pleased to see just 3 months later that DHHS shifted its recommendation in similar fashion. And this goes along with, I think, what Nancy Padian was saying about entities moving rather quickly on this information, quicker than usually happens in the public health world. Just a little bit about the details of the release of the recommendation. This was made by the commissioner and the mayor at the Mayor's Annual World AIDS Day event, and included a letter to all health providers through the city's Health Alert Network, or HAN. We were clear from the outset that the recommendation was made on the basis of both individual and public health benefit. The announcement also emphasized that the recommendation was for the universal offer of antiretroviral treatment, that no one was mandating or requiring pill taking, and you can imagine that was something that we got a lot of questions about. And the decision to start ART remained a joint one between a patient and his or her provider. We emphasized that adherence support was important where needed, and that ART should be provided by clinicians experienced with these medicines. Detailed FAQ documents were developed for patients and providers, which was not only made available with the letter, but also posted on our department's website. So I want to say, too, that on the face of the changed recommendation alone, that is, if one only looked at the number and share of persons in New York City who had a CD4 count above 500 and who would not already be eligible for ART under the prior guidelines, it would seem that this recommendation would not make much of a difference because it wouldn't really affect too many people. Fully 3/4, or 76%, of all newly diagnosed individuals in New York City for whom we have a record of a CD4 count in 2010, had a first CD4 count less than 500 at diagnosis, and another relatively small percentage would already likely have met criteria because of comorbid conditions under the older guidelines. However, we anticipate that the clarity of this new recommendation, offering treatment to all persons with HIV regardless of their CD4 count, it's a recommendation that for providers does not involve the kind of hair-splitting gymnastics of the prior iterations, is a paradigm shift, and it will contribute to improvement of outcomes across the spectrum. Of course, we have to evaluate whether the anticipated outcome turns out to be true, and this slide indicates how we're going to do that. Some of the metrics we'll be using to monitor the impact of the universal offer include the proportion of individuals with newly diagnosed HIV who have an undetectable viral load at 6 and 12 months, stratified by first CD4 count. We'll also look at time to viral load suppression, also stratified by CD4 count. We'll look at population-level viral load assessments among all the viral loads that we have reported. And another goose to Mike Cohen, we do have a picture of community viral load, which he had a very spirited debate with Mopli Da about at the last National HIV Prevention Conference, if you were there. We will also monitor primary drug resistance, and of course we'll be tracking closely all the key targets of the National HIV/AIDS strategy, most notably incidence. Note that the lower graph on the left, which shows time to viral load suppression, has already been significantly decreasing between 2006 and 2009, and that was long before we released this recommendation. We are also monitoring HIV in co-occurrence with other related communicable diseases. This map comes from a recent analysis we've been able to do with CDC funding for integration of some of our activities. We rank zip codes from highest to lowest for the prevalence rates in 2009 of 7 diseases: HIV, Hep B, Hep C, syphilis, TB, GC, and chlamydia. And then we highlighted, using the different colors that you can see, zip codes that have more than one illness in the highest quintile. And you can see that there are several zip codes in New York City in orange or red that are in the top quintile for all 6 or 7 of these illnesses. And obviously, these are neighborhoods that call out for an enhanced response. My last data slide is included to make the point that we have very important real-world precedents with respect to routine screening and treatment that clearly demonstrate the impact of this strategy. And I want to highlight New York's experience with this precedent here. During the mid-1990s, once pediatric clinical trials indicated that identifying HIV-positive pregnant women and treating them, as well as their newborns for HIV, decreased the incidence of perinatal HIV transmission, New York City instituted routine screening and treatment for pregnant women, and here is the result. After a peak of more than 300 babies born with HIV in the early 1990s in New York State, just a reported 3 babies were born with HIV in 2010, 2 decades later. So in New York City, we saw what an unequivocal evidence-based policy change in the mid-1990s regarding routine screening and treatment for HIV-positive pregnant women ultimately has done for the health of pregnant women and for the near elimination of perinatal HIV transmission in all 5 boroughs. So that transformation took at least a full decade to be realized, and it's my hope with the evidence, public policy experience, and political will that is mounting around this idea of maximizing outcomes along the treatment cascade for all persons with HIV, that we won't have to wait another 1 to 2 decades to reap the benefit of sound science and sound public policy. Thank you very much.
Thanks, Blaine. Apologize to the audience for going a little bit over. We did have a late start, but this is the last speaker of our panel. And Tom Coates is a premier behavioral scientist in the HIV field. That's an understatement. director of the Center for AIDS Prevention Studies at UCSF for many years, now director of the Global AIDS Center, Global Health Center at UCLA, and has been a part and parcel of some fundamental insights over the years, including his ongoing work in testing, and he'll be sharing some of this with you now.
Thank you, Stan. Does that fill the entire screen? I guess that's okay. Yes, so I'm proud to be from the David Geffen School of Medicine. I think it's the only school in the world, medical school in the world, named after an openly gay man. Although Jeremy Sugarman did remind me recently that Johns Hopkins was single, and we don't know why. And John Waters has agreed to make a movie of his life, so that'll be an interesting one. He's looking for it. It's coming. There we go. There we go. Okay. This is the study, I think, that was conceived when I was in utero, and the unblinding will be when they light my funeral pyre. Actually not. The unblinding will happen really quite soon. Now, how do I advance this?
Yeah. Behavioral intervention.
Oh, that one. Oh, wrong one. Okay, thank you. Oh, you think so, huh?
No?
Why don't you advance? Next slide, please. There we go. Okay, so we've talked about the concept behind this, and that is that there is a major challenge in HIV epidemics, and the fact that there are few visual clues to the epidemic, and that in all of this, one of the major barriers to the uptake of the new strategies and the new thinking has to do with stigma, and is there a way to destigmatize HIV in entire communities? So several years ago, we decided to test two approaches to HIV VCT. If you think New Yorkers talk fast, I'm from LA, I drive fast. So there are other approaches to HIV, and I think there's been this burgeoning of alternative approaches, the need to expand rapid HIV testing, routine HIV testing, couples testing, home testing, workplace testing, integration with other services, and we see our approach as an addition to that model. Now, I want to emphasize that this is not just sending vans out into communities. This is a complete package that includes outreach and community mobilization, VCT, and post-test support services, but the driving force behind it is data. And if you think about it, if you're an HIV test counselor, you'd rather give 2 positive test results a day than 8. And so motivating people in the field to maintain productivity, to reach the goals, is a major challenge, and is going to be a major challenge of the new studies. These are the 4 African sites. We are in Tanzania, in Kisarare, in Zimbabwe, in Mutoko, in Soweto, and Vulinglela in rural KwaZulu-Natal. This is a list of our collaborators. We started with a baseline survey, a cross-sectional probability-based sample of community members. We did community randomization, 3 years of intervention. The post-test assessment is completed. We had a qualitative cohort and cost-effectiveness analysis. I'll present some of the results today. This is just a view of rural KwaZulu-Natal. These are the testing vans set up. This is one of the community leaders, one of the Nkosi in the KwaZulu-Natal district, who went and got tested and looks like a happy man. We also did event testing around high schools, had debates, anything that we could do to attract attention. In Thailand, which was the 5th site, we got the religious leaders involved and did various community events. And I think as we do these studies, these community randomized studies, we have to deal with the realities of what it's like out there in the field. This is rural Tanzania. We drew crowds. We had the ultimate boombox, and got it out there. These are the colors that they used in Soweto. The idea was to make a big splash. As you see, the vehicle, the van pulling the trailer has a number on top. We also hired a tracker so that if our vehicles got stolen, we would send out helicopters and retrieve them. Only happened once. And in fact, the Nkosi, the chief in KwaZulu-Natal, when he gave the opening speech, he gave this incredibly moving opening speech. One of the things that they do there, of course, is they have the praise singers. And so when they introduce the Nkosi, they sing their praises and they sing their songs. And I told my staff, learn how to do that. I really like that. But one of the things he said was, how can I lead a nation if the nation is dead? And it was so inspiring. He said, I not only offer you my support, I offer you my protection. Nobody messed with us. It was great. Okay, so, and then more community mobilization. So in the whole project except HPTN 043, we did about 87,000 HIV tests, and you can see the differences in the pairs of communities and the number of post-test support visits. Now, these are data from a report published in Lancet Infectious Diseases in 2011. You can see the uptake of community members aged 16 to 32 in the intervention versus the control communities in the three areas where we could get a good handle on the standard VCT uptake. We're happy because we think we reached a relatively young group of clients. As you can see, even in Vulinglela, down to the median age was 21. There was gender equality. We know it's tough to reach men, and we did a very good job, we think, of reaching men. We also encourage repeat testing, and we will be doing a special paper on repeat testing. And the other important thing is that if one looks at the prevalence in the SVCT sites versus the CBVC sites, the standard VCT sites, the prevalence is higher. This is among testers. However, the number of identified positives is much higher. We see the cumulative utilization of post-test support services, and they were indeed very popular. People need time. We have a PEPFAR project in Malawi where we're implementing PMCT+, B+, and offering women who are identified with HIV the opportunity to go on ART for life. A surprising proportion are saying no. But imagine if you went to a visit and you said, oh, guess what, you're pregnant. Oh, guess what, you've got HIV. Oh, guess what, you're going on treatment for life. And probably in the process, probably what you need to do is go home. You need to tell your husband he needs to be tested. Your kids need to be tested. You need to tell your in-laws. I'd say, oh, yeah, I'm going to get right on that. So, you know, we need to think about how we're going to present this to people, and certainly the post-test support arm of what we did was quite vital in all of that. We talk about some of the testing and disclosure narratives over time and the reduction of stigma. We now are in the process of preparing a paper on secondary outcomes. This is a comparison. So think about this. We did a cross-sectional sample. We did the intervention. We did a second cross-sectional sample that will give us both behavioral outcomes, social outcomes, as well as incidence estimates. And in the secondary outcomes, we saw an increase in community norms regarding testing, more acceptance. We had increased testing uptake, increased identification of HIV-positive individuals, decreased risk behavior among HIV-positive individuals. I'm not giving you numbers because we're still making them precise and getting the publication ready for presentation. There were no differences in discussions about HIV, but the discussions about HIV testing in the intervention communities were more grounded in personal experience. No differences in HIV-related stigma, but it's a very hard issue to get people to admit to, and no differences in adverse events in the entire community or among those tested. And this is important, that we're not increasing harm, not increasing the opportunity for harm among people getting tested. The post-test intervention assessment that I said is done. This is a random probability sample of 18 to 32-year-olds in the intervention and control communities. This will be the basis upon which we determine whether or not we got a difference in incidence. You can see the prevalence rates. They would cascade as you would expect, with the highest in Vulinglela and KwaZulu-Natal, lower in Soweto in Zimbabwe and Tanzania, and very low in Thailand. The post-test intervention assessment, let me see if no, I don't go to that. The post-test intervention assessment, we started at a time when we thought that the BED assay would in fact be useful in determining incidence from cross-sectional samples. We subsequently learned that that's not the case. But working with Dr. Sue Eshelman, Mikhail Kulik, Deborah Donnell, and others, we have developed what we're calling the multi-assay algorithm. There will be a slew of publications coming out on that, and we believe that it's a highly sensitive and specific estimate of incidence that's available from cross-sectional assays, cross-sectional samples, and that will occur soon. The unblinding. This is the complete, again, I want to come back and emphasize the complete package. And I would also say that as I've gotten older, I understand that life is made of moments, and very special moments. And I think this is a very special moment in our fight against HIV. And it's like 1996 and 2000, and here we are. Isn't it remarkable where we've gotten? Thank you.